Well, thank you very much. It's an honor to be asked to come up here. Zvonko and Neil and I and a bunch of other people came along at a very opportune time, right in the very beginning of the possibility of doing things without open heart surgery. And that has been very, very gratifying. So I was asked to talk about TEER 2024. Where are we now? That's a good question, but we'll start with that. Let's talk about the MitraClip. I'm supposed to be talking about the MitraClip, I guess. In December of 2025, we did the first MitraClip procedure in this area. I guess we were one of 5 initial sites with the MitraClip. It was a 73-year-old woman who, as you can see, had a number of comorbidities. They had coronary disease and HIT, and she presented with severe MR. She was class 3 over the prior 3 months and was considered high risk for surgery. And she was enrolled in Everest 1, which was sort of the pilot trial for the MitraClip. So most of the regurgitation was coming from the middle of the mitral valve, a large regurgitant volume, the orifice area you can see, systolic flow reversal in the pulmonary veins, and severe left atrial dilatation, a little pulmonary hypertension, and moderate aortic regurgitation. So pretty high risk young lady. For those of you who've never seen one of these, this is a left ventriculogram. And you can see that the left atrium actually becomes more densely opacified than the left ventricle. And that, at the time, was a definition of class 4 mitral regurgitation, or 4+ mitral regurgitation. You can see by echo, she obviously had pretty much wide open MR. We were able to put in one clip in the A2-P2 segment, had a little trace MR afterwards, and then repeated the ventriculogram to quantitatively assess the MR, and you can see there really wasn't any MR afterwards. So she did very well. We lost her to follow-up about 5 years later, but that was the start. We then, I want to tell you one story about the randomization of Everest 2. We kicked off to Everest 2 shortly after Everest 1 finished up, and we were randomizing patients to either open heart surgery and mitral valve replacement or repair, or MitraClip procedures. At the time, we had 4 patients in the queue, 2 ministers, and 2 high-profile CEOs. And they were randomized, and the 2 ministers got the clip. So sort of a divine intervention, if you will. So this minister was randomized, got a clip at the A2-P2 coaptation. The MR was reduced to trace. And the question is, how long does this last? This was 17 years ago. Saw him in the office about a month ago. Repeated his echo, and he had trace MR. He's been asymptomatic ever since. So it's a durable procedure in many patients, and so I think it's very exciting. We then began Everest 2 and randomized patients to either open surgical repair via repair or replacement versus MitraClip. It was a 2-to-1 randomization. The percutaneous group was about 180 patients, and the surgery group was 95. We had echo, core lab, and clinical follow-up, baseline 30 days, 6 months, 1 year, et cetera. And you probably have seen the results. Basically, the patients were pretty much identical by all their levels of assessment. The interesting thing was the mortality rate was identical. The only difference, regurgitation residual was identical. The only difference was a number of the patients had to have re-intervention after the clip, so that the surgery sort of won. Now, you can see that there was pretty much equal a reduction in the MR and the improvement in clinical classification, maybe a little bit better in the clip arm. Then, sometime later, a new device came along by Edwards, the Pascal device. It was actually named for the husband of one of the research engineers at Edwards. And the locking mechanism, the grasping mechanism, was a little bit different than the MitraClip. MitraClip came out with 4 different devices, so we had a lot of leeway. So the question is there a lot of difference? I think in patients with complex anatomy, the Class 2D registry was pretty well equivalent. And so now that gave us the guideline for patients that are high risk with primary MR. It's a Class 2A recommendation for clipping. I think you can also say the secondary MR we did not do initially. Greg Stone did this trial looking at patients with secondary MR, and they randomized to optimal medical therapy versus optimal medical therapy foot clip. And you can see here death or heart failure hospitalization was improved dramatically by the clip placement. So that opened up a new area for mitral repair. The number needed to treat was only about 8 patients to show a benefit of clipping versus surgery. So the current guidelines say if you have low surgical risk or intermediate surgical risk in primary mitral regurgitation, mitral valve replacement repair is still the #1 indication. However, if you have high risk for surgery and functional and secondary MR, TEER is the way to go. Obviously, these days things sort of shift, and I think that mitral repair is getting by the clip procedures increasing fairly dramatically. Then the question is there really a difference between the Edwards device and the MitraClip? And I looked up, there's no head-to-head comparison, but a number of papers looking at matched cohorts, and pretty much the MitraClip and surgical repairs are very similar. I mean, the two clip procedures are pretty well equal in terms of outcomes. So we're going to conclude with that, and this comes from Dr. Doble, it's his slide, but most of mitral valve regurgitation patients can be treated with transcatheter therapies if deemed appropriate by the heart team. TEER is standard of care for 3+ secondary MR in patients who remain asymptomatic despite guideline-directed therapy from the COAP trial. If you embark on doing these procedures, you really have to have a world-class echocardiographer, because it's really an echo procedure almost. We have to have pristine guidance by our echocardiographer. I think we also need to consider, if you have access to both devices, mitral clips don't do well in the commissures, so if you get into that area, it might be better to consider the other device. And then obviously calcified valves are difficult to treat, and that's sort of where we are. Thank you.